Hi, everyone. Welcome to the Be Her Village podcast. I am Caitlin McGrayus, founder of Be Her Village. Our podcast is a really interesting mix of all the different services and professionals that we have listed on the Be Her Village gift registry, as well as talking to mothers who have shared their experiences with us about birth and parenting. So today, I'm very, very excited to introduce to you our guest. She is a friend of mine. She is a Gaia midwife. She is the medical director of Timothy Hill Children's Ranch. She is a women's health nurse practitioner. She is a certified nurse midwife. She was an L&D nurse for 8 years. She was a nurse before that since 2004. She's been a doula since 2002, and she's also a clinical instructor for nursing students. There is very little that she does not do, and I don't know when she sleeps. And her name is Colleen Heinze, and thank you so much for joining us today.
Thanks for having me.
So Colleen and I have worked together. Let's see, I've been a doula with you many times at many of your Gaia births, home and hospital. Actually, I was the doula for your transfers, and we'll get into transfers, at Stony Brook, Newmick, and South Nassau. We were the doulas on each of those births for your very first experiences there for home birth transfers.
Awesome.
So that's like a badge of honor I have on my resume. That's what I list. And I also have assisted you as a midwife at home births as a Gaia birth assistant. So today I want to talk to you about, I think we could probably spend like 10 hours talking about all things birth and women's health related, but today I really want to get a sense of what is a midwife, because I think the people that are listening to this show are birth workers, and they are also pregnant people. Mm-hmm. And I think that the word about midwife is starting to get out a little bit, but there's a lot of confusion in terms of what are they? Are they the same thing as a doula? Are they the same thing as an OB? What can they do? Is it only for, crunchy granola moms? Is it only for home birth? And I think we just should start is what is a midwife? So if you could just sum it up and tell us a little bit about your work. What is a midwife?
So you would think that would be an easy answer. But there's different pathways into midwifery. I am a certified nurse midwife. So I started with an undergraduate degree in nursing. I went on to get a master's degree as a midwife and a postmaster's in women's health. We are your basic women's healthcare provider. Just to make it very, very simple. But what that means and where a lot of the confusion comes in is some people say, well, I only use a midwife if I'm pregnant. Well, that's not true. We take care of women from their first period straight through menopause. And we can deal with, all the things that kind of come up in and with that. We do pregnancy care, and we obviously catch babies, and we do postpartum care. We do birth control. We do just your annual physicals and checkups and things like that. We can do blood work. And a little bit depends on the state. So I should probably qualify this by saying that I live in New York State. So in my state, I have full prescriptive privileges, and I'm an independent provider. So I can write all my own prescriptions. I can send people for tests. I can get those test results back. And then part of my job is to then refer people out to the appropriate care provider that if they needed, ongoing and further care that was out of the scope of midwifery. Our expertise is normal supportive care. We are trained to recognize the pathologies and to deal with some of them. But once things get to a certain point, we have a wonderful team that we collaborate with, and that helps to support our patients and ongoing care.
Thank you. Wow. So I just want to go back and underline something. Mm-hmm. The part where you said that you're independent providers. So midwives are not, and I know that probably in the past this has been different, but right now midwives are completely independent, meaning Gaia Midwives has their own practice. You're not asking permission from, and I know there's collaboration, but you don't have to have a doctor
Correct.
supervising you or checking your work or writing your prescriptions for you. You are able to completely care for a woman through her pregnancy, obviously through the entire span of her fertile life, it sounds like, from first period to menopause. but you are completely independent providers.
Yes, and I mean, we are, part of our licensing says that, you know, as responsible licensed providers in the state of New York, again, this is for the state of New York only, although many other states do meet the same standards as New York State. It's a good idea for us, and we should have a good network of people to collaborate with and refer to, because there are things that fall outside of our scope. And so that is one of the things that it says in our licensure, is that, you know, you have to have somebody that you have a good enough relationship with, that, you know, if you have a patient that needs something beyond your scope of practice, you can get that patient the care that they need. But yes, in New York State, we have our own practice, and we are not, although we carry private practice privileges at several hospitals, we are not under those hospitals, and we are not under a physician. We are our own practice. We have our own set of practice policies and our own standards of care, and that we strive to meet. And then we utilize the other providers within our circle in collaboration with our care.
Awesome. So let's talk a little bit, just to kind of back it up. I mean, this is great information, like the technical, but I want our listeners to have a real sense of what makes midwifery care different from their standard. Like, why, my understanding of it is essentially, like, in terms of what midwives can and can't do, midwives can do everything except cesarean sections. In terms of birth care, right? You can do pretty much everything. You can do
Pretty much
inductions. You can do, support a woman who has an epidural. You can support women in the hospital. You catch babies at home. So the care doesn't look all that different, but, well, I should say, like, the clinical, the care looks,
I was gonna say,
like, yes, the care looks extraordinarily different. And that's what I'm trying to kind of get at here.
Yeah.
Is that the midwifery model of care, as somebody who has, personally, I've used midwives and OBs and then midwives again, the midwifery model of care, can you just speak a little bit to that, of how that looks different from the medical model of care? So what are women getting when they go to a midwife, and what are they getting maybe when they go to a standard OB?
Yeah, so I think there's three main differences. I'll list them and then I'll kind of elaborate on them. So the first would be that midwives view birth, in the midwifery model of care, birth is viewed as physiologic, which means a normal life process. In the OB model of care, it's viewed as potentially pathologic, which is, you know, basically a problem waiting to happen. In the midwifery model of care, the woman is seen as the decision maker, and in the OB model of care, the responsibility lies with the provider. And the third point is that in the midwifery model of care, shoot, it's gone. I'll come back to that third point.
So there's really two main important.
There's a third one somewhere floating around in there.
It'll definitely come back.
It'll definitely come back up. But let's start with the first one, which is the fact that physiologic versus pathologic. You know, so when a midwife approaches a woman in her pregnancy, and we sit down and we establish a collaborative relationship between ourselves and the client, you know, we are looking at this person, unless they come in with a whole host of health issues to begin with, as a normal, healthy person who is most likely to have a normal, healthy birth. And that's how we go throughout pregnancy, and that's how we go throughout the birth process. And until proven otherwise, you're going to be treated as a normal, healthy person. Whereas when you come from the obstetric model, the model says birth is dangerous, and there's a lot of things that can go wrong. And so the more involved in the process we are, the more we can hopefully mitigate the risk that comes with birth. And so that's what that is. The provider in the OB model takes a greater sense of not sense of responsibility, because I feel an incredible sense of responsibility. But that, you know, the feeling is that the decision is mine to make. You know, you need to be induced at this point because, you know, I don't like my patients to go past 41 weeks. Whereas I will have a conversation with my clients, because coming from the midwifery model of care, it may not be in my comfort zone for you to go past, 42 weeks, but that is not my decision to make. My decision, my responsibility as a provider is to give you all the actual numbers and the actual data, and to educate you as to the risks and benefits of both sides of it, because there's nothing in this life that is a zero-sum risk. So if there's going to be risk involved, the client should have the right to say which risk they would rather assume. And so my job is to educate you as to those risks and benefits, and to help you make a decision for yourself, your care, about where you want to go. And of course, if I have a very strong opinion on something, I'm going to say, this is really what I think you should do, but what do you think? How do you feel? Because
go ahead.
not my body. It's not my decision to make.
It's so interesting. Just even the way that you just spoke, it really, like, the language that women hear in pregnancy. How many times do we hear pregnant women say, oh, well, my doctor won't let me do that. Or no, they said I'm not allowed to go past this. Or, I have to do this test and I have to do this. And it's like, there's this feeling and this sense, but I see it as a doula, and I'm sure you see it as a midwife, especially patients who are accustomed to this type of care entering midwifery care, where it's like, oh, I have a seat at the table, and we're going to collaborate together, and you're going to bring me information, and we're going to make a decision together. There's this sense of walking into an OB's office, and you kind of just like hand over everything to the doctor. Like, they just, and I don't mean that in a good way. Like, it's more just like you become passive and quiet, and they dictate to you exactly what is going to happen. I did a podcast with Rachel Parada, who's an incredible pelvic floor physical therapist. And she and I spoke about consent. And it came up that, like in standard obstetrical appointments, it's kind of like, lay back, I'm checking you now. And there's no, there's no like, hi, okay, this is what I'd like to do today. And if you're comfortable with it, I can do it this way. And I can tell you, what I'm about to do and how it's going to happen. And as soon as you say no, it's finished. And there's this like ongoing consenting happening throughout her appointments. I would imagine that that's happening in the midwifery model of care, or at least in how, I should say, and we're going to touch on this a little bit, in how you practice midwifery. Can you talk a little bit about that in terms of what consent looks like in your practice, and how that may differ from obstetrical models of care?
So I actually don't like to use the word consent so much.
Okay.
I mean, it's a fine word, but I like to use the word choice.
Okay.
And actually, that was my third point that I finally did remember, which is individualized care. But the reason why I like the word informed choice over informed consent is that choice implies that there's another option. Consent implies that I came in, I told you this is what I'm going to do, and you said, okay, but you don't know any of the benefits, risks, alternatives. No one asked you what your intuition said about it, and no one told you what doing nothing would do either. So like we go through the brain process, and that's one of the things that, we in our practice work through with all of our clients in the decision-making process, is we really attack the brain, the benefits, risks, alternatives. What does your intuition say? What would happen if we did nothing? And we talk through all of those things and allow you then to make a choice about what is going to be best for you. So yes, there's consent, because patients always say, you may do this, but it's after we've had the long conversation about the choice to even get into whether or not we're going to do X, Y, and Z. And just an easy example is birth. You come to someone's birth, whether you're home or hospital, and there's an assumption on most people's part that you're just going to get vaginal exams a lot, because we need to know what's going on. And there's some times where we do need to know what's going on, but it's less common than you would think for the number of vaginal exams that occur. It kind of just gives me information, but not a lot of it is actionable information. It just tells me where we are right now. And if I ever get to the point where I think I feel that there may be a benefit to an exam, or I feel maybe a patient would benefit from an exam, because sometimes you can watch a woman's mental state kind of starting to change throughout the labor process. And sometimes I'll suggest, might be a good idea to know where you are in labor. This is why we might do it. Here's how we would do it. And some women are like, yes, I need to know. And other people say, you know what? Nope, I'm still okay. I think I just want to keep going. Great. That's totally fine. It's your choice. It's your body. You can decide what happens to it. So
that's wonderful. So I would like to just really quickly sing your praises because I want to kind of like pivot into this conversation about the different types of midwives that are out there. And so the thing that I tell my doula clients is, it's wonderful that you have a midwife. Of course, it's wonderful that you have a midwife, but midwives are operating within a system. And so they're not immune. Even you guys, and Gaia is just, let me start there. Gaia is the most supportive midwifery practice that is really putting your money where your mouth is. The three of you, you, Amanda, and Ashley, the Gaia midwives, you guys really, like, you don't sit here and tell me all this in a podcast and then go do your own thing. Like, I've seen you guys in appointments. I've seen you guys, I actually see you guys for my own well woman care. I've seen you at births. I've seen you at postpartum, and the way that you speak to women and really include them in their care, it makes a difference. It makes a huge difference in how they feel about their birth, because there's so much that we can't control about birth, and there's things that we can't control about, like the medical things that come up. But when you hand control over to a woman about the things that she can control, it changes how she feels about her birth. So that being said, that Gaia is just hands down, I'm going to go out there and on a limb and say, like, the best midwifery practice that there is on Long Island right now. And that is not to knock any of the other ones, because the midwives on Long Island are working really hard in difficult situations and like making ground, and shout out to the Stony Brook midwives and Melanie Summersill. And like, there's just so many wonderful Long Island women are very lucky about our choices. But the home birth and like the care, the really individualized care that you guys are giving, it's just incredible. So what I want to talk about a little bit though is, when I gave birth for the first time, I hired midwives, and I was supposed to give birth at an out-of-hospital birth center, and I didn't hire a doula, and that's going to be like a whole other episode.
We love doulas.
Yeah,
they're great.
but I mean, maybe you could speak to this a little bit, but like, I thought if I just hired midwives, I didn't need a doula, so I didn't hire a doula, and then I got this, what I now call as a doula, I got the bait and switch. So it turns out that my midwives were working with an OB, and were actually like, they were being overseen by an OB that I had never met. And in like an instant, they got a phone call and the OB said, induce her. And I was induced. I suddenly was like understanding I was under actually like OB care. I was in the OB model of care with like midwives representing. And my midwife put me in the hospital and got me all set up and left, and didn't come back until essentially it was time for my C-section. And my own experience with midwives, my first time around was really awful. It was awful. And I hesitate sometimes to tell that story, because I am trying to like educate everybody on how amazing midwives can be. But I think that in fairness to pregnant women, I want to talk about how we can interview providers, and how can we make sure that the midwives that we are working with are actually practicing the midwifery model of care, and how do people navigate midwives that maybe are under pressure in their hospitals or have external factors that aren't really letting them deliver that truly midwifery model of care. How do you handle that? Do you see that sort of thing in the midwifery community?
Yeah, I mean, it's hard. I'm so blessed to be doing what I'm doing, because myself, Ashley, and Amanda, we are the deciders for our practice, like what kind of comes and goes. But when you're working with and under somebody else, you are bound by certain hospital regulations, practice regulations, and other things. And, as a midwife that is working in collaboration or underneath an OB, your livelihood depends on maintaining a collaborative relationship that's, healthy. So it can get kind of sticky. I just want to throw in one thing, because one thing that you said when you had such a rough experience with midwives, when I'm talking to women about midwifery care and care in general, I always tell people some people are like, oh, don't go to that hospital. That hospital has a high C-section rate, or this, whatever. I say it's really down to the provider, and whether it's an OBGYN or a midwife, it is who's going to truly listen. And I think that's part of the interview process. I've seen phenomenal OBs that truly listen, that follow a woman's intuition. I've had OBs get on the floor and catch a baby on all fours on the floor of Stony Brook Hospital, which is just amazing. And I've had midwives yell at women and tell them to stop yelling and shut up and push, and so it kind of runs the gamut. I've seen all kinds of things happen, and it really depends on your provider. So interviewing your provider and getting that sense, because you can ask questions and people can give very good answers, but the question is, was the question taken seriously, and was your concern taken seriously, whether the OB thinks it's important or the midwife thinks it's important or not, or it's even, it might be a completely silly question to them in their mind, but if it's important to you, it doesn't matter. That answer should be given with all due respect and attention and detail, and not just blown off. If you find that your answers are being just dismissed, like, oh, that won't be a problem, don't worry about that, like, that's kind of one of the first signs that maybe it will be a problem, because we're not actually discussing, what this could look like. And of course you can't think of every kind of scenario, but I would say that in general, you can get a sense from somebody when sitting and talking to them, if your questions and your concerns are being given the due respect and attention that they deserve, because any question that you have is a valid one, and it deserves an answer that's thoughtful and speaks to the point of your concern.
Absolutely. And I love that you said that, because when interviewing, first of all, let's just talk about, you should be interviewing people, right?
Yeah, absolutely.
I think people, with doulas, they are interviewing so many doulas, and I highly encourage that. I think you should talk to people, because the money is coming out of their pocket for their doula. And so they really feel the impact of that, and they want to make sure they're picking the right one. Mm-hmm. But somehow women will interview 6 doulas and then say, oh, well, I'm going to that gynecologist because that's who I went to when I was 13. It's like, with mm-hmm. no care or that's who my aunt used, or that's who delivered me, so I'm just going to stay with that practice. Even though in their appointments, they can't, sometimes you kind of, you talked about there's that blow off of oh, it'll be fine, don't worry about it. So there's that doctor that's like, oh, don't worry about it, we're not going to get into specifics, but it's all going to be fine. Mm-hmm. Or you have the doctor that is just running the appointment to the point where women don't even feel like they can ask a question. Mm-hmm. Which, what I like to say as a doula is however you're made to feel in your appointment is how you're going to feel in your birth times 1,000, right? So if you feel like you don't have even a minute to ask a question, or you feel nervous asking a question because you think your doctor will take it as a challenge, or there's this, I don't even have the right to ask a question, well, then you're going to feel like that even more when you're in the throes of labor. Mm-hmm. And if your doctor is dismissing your question, even if it doesn't feel dismissive, if it's just well, don't worry about that, we'll deal with that when it comes, it's super dismissive, because many women like to prepare. Mm-hmm. I'm actually thinking of our shared client, Kimmy, who I was her doula, and she found you guys because I said, oh, you're looking for a different person. Maybe you should call Gaia. And the thing that she brought up is that she went to her OB in Manhattan, and they told her, she asked a question, and they told her to not read any books about pregnancy and birth because it'll just scare her. And she was a librarian student, she's a librarian now, and reading was her entire life. And so for someone to tell her to not get information, it was a huge red flag went up, and that's how she found you guys. But that dismissiveness, that is just, it's really difficult, and it's a huge red flag. So I love that. It's even if you hear answers that kind of seem okay, pay attention to how you feel when you're in the room with them. There's more than just the verbal answers. It's how do you feel? Do you feel like you have a voice? Do you feel like you're confident in your care provider? So can you highlight a little bit, we touched on it earlier, what is the difference between a midwife and a doula, and do you need a doula if you hire a midwife?
Yes. So when we talk about midwifery care versus doula care, when I went through my doula training, and I'm sure the same thing, hopefully for you in your training, it was made very clear you are not a medical professional, and you are
We
not
spent like a whole
here
day on that.
to give medical advice, and you are not here to make sure the woman is healthy and safe. Like, your job is emotional, physical, psychological partner support. And is that something that I as a midwife often do? Yes, of course. But at some point, my primary job is to make sure that you are safe and that your baby is safe, and to maintain that level of safety. So my mind is split. Like, I'm watching all that stuff, and I can't be 100% on your emotional and physical and psychological like well-being, even though that's a big part of what I do. Safety has to, trump kind of everything. So I need to make sure that you have a safe space in which to bring your child into this world. A doula's only job is to be in your face the entire time, or pushing on your back or pushing on your hips. They don't have to stop and go document. They don't have to write anything down. They don't have to listen to a heartbeat. Like, their job is 100% you and your support and your emotional and psychological well-being, and we love doulas. We work with them all the time. We recommend one to every single one of our clients. It's actually one of our, we have a little, I would call it like a cheat sheet at the top of everyone's chart when we start writing notes, where we list a couple different things. And one of our pieces of data on our cheat sheet is, who is your doula? And we basically keep asking that every week until we either get a name or they say, no, we're really not going to hire one.
Right.
Because we think it's that important. Like, we want to make sure that you found someone to work with, or that if you haven't found one yet, that you're working on it, because doulas book up, especially the really great ones like y'all. So it's, we want to make sure that you guys are, out there and finding your doulas early enough, and interviewing a lot, just, like we talked about, because you need to find someone that's going to vibe with you, in the best way. It's a very intimate, it's a very personal relationship between a doula and a client. And it's a lot about the emotional, and I would say almost like a spiritual connection that you have with that person. And if you're not interviewing and you're not finding someone that like has that same vibe as you and your partner, then it'll be a good experience, because the doulas are great, but I mean, you really want to find someone that's going to just kind of fit into your family life and into that, the feel of who you guys are as a couple. So
absolutely. And I think similar to midwives, and providers, doctors included, I think that there is a doula and a midwife for every single person, right? And it's not like there's one perfect, like when Kathy and I are recommending midwives to people, while I sing Gaia's praises left and right, a lot of people want something else or have different priority. And so we kind of like help people, we help get to know what they want. And since we know all these practices so well, we help match them with those practices. One of my favorite examples of this is, in the same week, I had somebody that was with Stony Brook Midwives and somebody that was with Melanie Summersill. And they were both unhappy with their care. And so as their doula, I recommended the other midwife to each person. So in the same week, somebody switched from Stony Brook Midwives to Melanie, and one of Melanie's patients switched to Stony Brook Midwives. And both women were so, so, so happy with their support and with their birth. And they were just absolutely to the moon about everything that happened. And I thought it was such an interesting example of how each practice, OBs, midwives, and each doula, they all have such a different flavor and a different way. And you really have to like interview and understand what that way is and if it matches with what you're looking for. So it's not just like there's one perfect provider, one perfect doula. It's really, it's like a heart thing. It's a felt thing. You feel good in the room. Do they laugh at your jokes? Is there something they do that's annoying you? Because if they're annoying you right now with your clothes on when you're not in labor, they're really, it's not going to go well.
Yeah, absolutely. And like part of our practice policies actually is that unless you're a GYN patient or a return patient, it's a standard that we don't even take a client on until they've had an official meet and greet. Where they come and they get a chance to sit and ask all those questions, because we feel that the interview process is so vital. And we may not be the practice for you, like we might be the perfect fit, but we want you to come with no obligation and sit down and have a chance to really talk and see who we are, what we're about, ask every question you can possibly think of,
Mhm.
and then go home and discuss it with, your mom, your partner, whoever's, impactful in your birth process, and decide if this is right for you, and then sign on as a client.
That's
Because we
great.
don't ever want anyone to walk through the door going, oh my gosh, I wish I'd asked these 4 questions first,
Right.
It's
I
because
would
you would change to ask all
imagine
those.
I would imagine that that is also a two-way street for your practice, and maybe that's something we can kind of go
Hmm.
into in terms of selecting clients. Is midwifery care right for every single woman? Does Gaia have women that they say, "I'm sorry, I can't work with you," if it's a medical thing or a personality thing? Could you speak a little bit about what that process is for you guys, and who is eligible for midwifery care? Because I think we get this sense that it's like only the lowest risk women. What does that even mean? Could you talk a
Hmm.
little bit about that?
Sure. And I'll speak specifically to my practice, but
Okay.
if, in general, it's different for every midwifery practice, because every practice is aligned differently with different providers. So different providers, different women feel comfortable, different midwives feel comfortable taking on different clients. And so it's kind of one of those things where you have to shop around a little bit. Um, we, as a practice, have a set of practice guidelines that we operate off of. Guidelines obviously not being strict, we can kind of flex here and there depending on where we need to. But we have had a couple of women that we've recommended to other practices, because weren't a good fit for them. I would say that if you came in and you were already an insulin dependent diabetic for our practice, that's probably, you're going to need a hospital delivery anyway, at that point. And, you run into some other issues, health wise. So being in a practice where maybe the Stony Brook midwives that could have a very good collaborative relationship with the OBs already there, so you can have that direct, really seamless transfer back and forth of care, would be more appropriate than coming with us. We've had someone call up after 4 cesareans wanting to see if we would do a VBAC, and that's just not something that it's a little outside of our scope. We firmly believe that women should have the option to choose what they're going to do with their bodies, and we've recommended other providers that are hopefully willing to support them in that pursuit. But that's for us, kind of some of the things that might risk you out of people that are already on blood pressure medication prior to birth. That's something that would probably risk you out of our practice, because we can get into all the kinds of things that can happen in labor and birth. I don't want to get into those things too much, but so that's kind of where we land. But for the most part, we really do believe that most women are appropriate for someone's midwifery care. And that's why it's great that there are midwives that are practicing in so many different arenas. And we have midwives practicing hand in hand with maternal fetal medicine specialists, which are like the highest of high risk doctors, and they can still have access to midwifery care, even if they need and they require that level of oversight, in their pregnancy. And then there's, people like us that, who take on, a mix. We have, women that aren't, on various medications, that have had C-sections in the past. We have, they're all part of our clientele, but they don't fall into that, probably every other visit should be with an OB category.
Right.
And we deliver at home in, the lowest of lower settings. And we also do birth in the hospital, but about 85% of our clients are primary, initially home birth clients. So,
Wow.
mhm.
So let's talk about home birth, if you don't mind.
Yes, please.
Okay.
Love it.
So I have to admit something, and it feels a little absurd to admit it. But when I became a doula, I was 5 months after my VBAC, and my VBAC was a transformative moment that I will talk about in another episode. But I became a doula, and I literally said the words out loud, I don't believe in home birth. So
Mhm.
I was fully supportive of women and fully supportive of birth of all kinds, but I didn't believe that home birth was safe. I didn't think it was smart. I was kind of like, I had this attitude, and I had lots of personal growth in the 5 years since I've become a doula, which is why it feels funny to have these words come out of my mouth, especially in an interview with an awesome home birth midwife. But I think probably some of the people listening have the same feeling. And that's why I'm admitting this is where I was. I thought our medical technology has advanced so much that how can you say, I'm not going to take advantage of that? How can you birth at home where it's dangerous? So I obviously had quite a transformation because I then was a doula and then ended up having my third baby at home. So I have made a transformation. I'm happy to share that, but I want to hear from you. What do you say to people that say that home birth is not safe and that it doesn't make sense and it's not something that should be done, which I'm sure you're hearing that because that seems to be the mainstream medical community's view on home birth. So can you speak to the safety of home birth and what that looks like?
Yeah, absolutely. So home birth is safe when it is appropriate for the person choosing. So I will never, if you're ever coming for a meet and greet, you sit with me especially, you're going to hear this like phrase that we are not a home birth or bust practice. And we are also not a vaginal birth or bust practice. Our goal for our women coming in is that, because we also have to have personal goals for our clients, you know, so our personal goal for our clients is that they feel safe and that they feel informed, and that regardless of location or mode of delivery, they feel like they had a say, they had a choice, and that whatever happened was what needed to happen, and that they feel comfortable with the process. They can still grieve, you know, over the loss of their ideal, because that's just normal. But we would never want a woman to say, I felt bullied, I felt pushed, I felt like I didn't have a choice, or I felt like it probably didn't need to happen, you know, that I got forced into something that wasn't necessary. So that's our goal for our clients, is that they have that understanding. So when we talk about home birth and the safety and efficacy of it, then yeah, there is a little bit of a client, you know, selection process in some ways. But looking at the majority of women that walk through our doors, I mean, the majority of women meet criteria for having a home delivery. And so once that has happened on our end and we feel comfortable with that, I would say that, you know, if you just look into the statistics, I mean, I'm a numbers person. I find statistics comforting. The numbers really support home birth for the appropriate woman. You have to, of course, you know, remove the ones that shouldn't probably have been at home in the first place, you know. But once you look at women who are appropriate for home birth care, those numbers really come up even with women at the hospital, at least, if not slightly better, as far as like, you know, fetal outcomes and things like that. The babies do just as well. Women tend to do better at home than they do in the hospital. And I think part of that is because of technology, I think, is a two-edged sword. It's both a blessing and a curse. It's amazing the things that we can do with technology now. We're saving lives. We are preventing, you know, we're saving infants, you know, we're preventing a lot of negative outcomes in some ways. But I also think that in the same, you know, turn of phrase, that technology has done a lot of negative things for us. We have, you know, over medicalized the birth process, and we have actually introduced risk to women in some ways. And so if you start looking into things like the statistics on maternal mortality in our country, and even going beyond that, and the statistics on women that feel emotionally damaged after their births, which is a really important thing that is not really addressed, because the general consensus is, well, as long as everyone's alive at the end and mostly okay, like physically, then we did a fine job. But it's more than that. You know, these women, you know, go on, and I'm sure you can talk about, like, after your birth, you said your VBAC was so transformative for you. But there's scars that you carry from birth to birth and throughout the rest of your life, you know, that kind of hang on to you. So as me as a provider, you know, we might be done, I mean, hopefully you come back to us for GYN, but, you know, at 6 to 8 weeks postpartum, and, you know, that's it. You know, we did our job for you, and hopefully we did it well. But if we didn't, like, you continue on for the rest of your life carrying the burden. So when we start talking about, you know, home birth, it becomes more about, are you appropriate for home birth, and are you comfortable in that setting? Because if you are, statistics would say that it's a safe place to be. The other thing I'd like to point out is that all the studies that have been done on home birth and out of hospital birth, let's just call it community birth, because we got birth centers as well, is that it's safest when it's in cooperation with a medical system, which is why we feel so strongly about carrying hospital privileges, because it allows us to offer women the chance to, you know, transfer into a hospital setting if they need to or want to.
Mm.
The main reason for transfers out of our practice is, or not out of our practice, but out of the home setting and into a hospital setting, is for pain relief. Women that's, been doing it for, you hit a line, and for sometimes 47 hours is just long enough. And you're just, I'm done. I
Yeah.
want an epidural. I need like 5 hours of sleep before I have this baby. Great. Not a problem.
Even I, as the doula, I want an epidural after 48 hours of sleep.
and that gives us the chance to like afford women that opportunity and that service.
Yes.
And if medically you need to, then you also get the chance to transfer in and receive appropriate care while not losing connection with your provider, which is,
Right.
really valuable.
So I have to say, I just want to like kind of come full circle to how my perspective changed. And you really just hit it right there. When I was selecting a home birth midwife, I was only selecting one, and there was only one on the island. It happened to be who I wanted to work with. But at the time, there was the only one in the area that had hospital privileges as well as did home deliveries.
Mm-hmm.
And that was so, so important to me. And part of it is because, like I said earlier, I have this view of like home birth, you're giving up all of this access to medical care. How could you give up everything we've worked towards?
Mm-hmm.
All of the advancements, all of the money, all of the expertise. How are you giving that up? And what I realized, and what really shifted me, well, I realized two things. One is that many of the emergencies that happen in birth happen because of the interventions that it's the cascade of interventions. You do one thing, then a complication happens. You do the next thing, a complication happens, and suddenly your baby's in distress and you need a C-section. So number one, it was realizing that most of the things that happen rapidly and suddenly are due to actually medical procedures that are happening. But number two, I realized that in choosing to deliver at home, I was adding an option for myself. So I kind of thought, well, if I plan a hospital birth, I'm definitely giving birth in the hospital. It might be a C-section, it might be a vaginal birth, and I'm okay with either of those. And if I plan a home birth, I will have the possibility of delivering in my living room or my bedroom or the shower or wherever women deliver their own. Lots of stories.
Backyard.
But I felt like I was adding on this option. Like, why don't I start at home? Because I'm going to start at home anyway. I'm going to labor at home. Instead of laboring on my own, like I did for my VBAC, I labored on my own for 20 of the 21 hours. I was only in the hospital for an hour with no medical care. Why don't I have a midwife that's trained with medical, and we could talk about what you actually bring to a birth? Why don't I invite them into my home and get high quality, individualized medical care with somebody in the room with me? And if we have to transfer, then we transfer. But in my head, there's no such thing. Well, there is such thing as a failed home birth, but a failed home birth to me is when somebody gets hurt, a baby or a mother. A failed home birth to me is not starting at home and transferring to the hospital. That is exactly how home birth is supposed to work. It's adding an option on and making a decision in the moment based on safety, based on preferences. But there's no such thing when you have a happy mama and a happy baby, even if it ends in a C-section, it is not a failure. That is exactly how home birth works. Home birth includes all of those medical options.
Correct.
And I love that you guys value that model where you're collaborating with physicians, where you maintain hospital privileges, and it really brings home birth, it legitimizes it to me, right? Because instead of being like this deep, dark thing that happens under radar, it's like you guys are shouting it from the rooftops. You're posting on your Facebook, about these beautiful, safe home births that happened. There's nothing, I don't know, there's no shame in your work. And I don't feel that sense of shame. It's like you seem really proud of what you do.
We are, and we love the fact that we collaborate. And part of what we want to do is to bring home birth out of the darkness, kind of like into the light, and make it more. Whether or not you end up agreeing with home birth and you think it's what you want to do for yourself or your family, that you would recognize, and the medical community would recognize it as a legitimate option for some women. And so, one of the things we do is when we have a birth within the catchment area of one of our hospitals, we call them and we say, hey, having a baby in Patchogue, Stony Brook, just letting you guys know we're, here having a baby. And then we call after the baby's out. We're like, had a baby. Thanks so much. So
you're calling and collaborating with the hospital before there's an emergency, or even
before this emergency, and also to let them know that we are, here and that it's happening, because, they don't always follow our Instagram page or our Facebook page, so we want and oftentimes when you're working as an OB in a hospital, and especially prior to our, our practice and the collaboration that we've been so, blessed with to have with, these institutions, the only kind of home births you saw were home birth transfers. And, sometimes they were appropriate and good, and sometimes they were not. And so that's the only thing that's in their mind. So our goal as a practice is to just make sure that we let people know when it's happening, and that it's happening, and it's happening frequently and normally, and everyone's good and healthy, because it gives us a chance to hopefully over time change the impact of hearing the word home birth in somebody's heart and mind. When they hear it, they're not scared of it anymore. They're like, oh, that's happened 7 times this month and everything's been fine. We haven't seen any of those patients walk through the door, So whenever we do come in with a transfer, which, we come with all of your records, we come with the patient, and we come, completely settled, and you're still our patient, especially at Stony Brook or South Nassau. Mm-hmm. It's not like this, oh no, a home birth transfer is coming, and they're like, oh, okay, that's fine. They've got it. So, right. I mean, our goal is to kind of make that mentality shift within the culture of the hospital setting, because we do feel very strongly that we all started with, medical roots. We all started from, Stony Brook. Amanda was, worked with them for a while as a midwife. Ashley and I were both there as nurses. And we appreciate and we value our relationship with that institution because we value what it provides for our clients and the excellent care that they receive. And we've done beautiful, beautiful vaginal births there. And we have had some amazing supportive belly births at that hospital as well. And it's just been a beautiful relationship, and one that we're looking forward to cultivating and growing, and hopefully continuing to provide as a real asset to our clients. So if you're doing home birth, you should have a statistic that involves a transfer, because if you don't, then you're not doing something correctly. You're doing a disservice to your clients in some way, because not every birth is going to go 100% smoothly for your entire career. There's going to be times where women are going to want and or need that higher level of care. Mm-hmm. And so, we're very proud to say that, yeah, we have a transfer rate, and all of our patients, I'd be happy to let you talk to any single one of them that had a transfer. I think they're all going to tell you the same thing. Yeah, we wanted a home birth, but it went great. Mm-hmm. And that's our, like I said, once again, that's our goal. Our goal is that women at the end of it will say it was what it needed to be and it went well. And I feel good about what happened. So.
I mean, so speaking as a doula, I have been with you guys for transfers, and I'm thinking of the first one that me and you had at Stony Brook, and it was, so I was sobbing. I was sobbing at the end of that birth. Colleen, if I could just speak a little bit about it, it was just to really to hammer home how when you transfer care, you're talking about, and it's so important, changing the medical understanding of home birth and bringing it really into this legitimate place. But for the client to be able to walk through the door with the midwife who's been with them and then continue getting care from them. The first transfer you guys had at Stony Brook, she caught her own baby in the bed. And I've been doing this a long time, and I don't cry at every birth. I don't even know if I cried at my own birth, but there was something so beautiful. The room was so dark and nobody was touching her. I mean, the nurse had stepped back and you stepped back. And I remember I was standing there and her mother was there and her partner, everybody, we created this beautiful circle around the bed. And she just was there on her own in her power. And she was easing the baby's head out. I'm going to get all talking about it. And she reached, the baby's head was out, but we were waiting for another contraction. And so she just started stroking her head and talking to her baby. Oh my God, it was the most beautiful thing. And that is what Gaia is doing in hospitals, at home. It's this care where women are just at the center of it, and they're so supported, and they are in their power. They're catching their own babies in hospitals, or their partners are catching. And it's so beautiful. The other home birth transfer, sorry, I'm just gonna all these amazing births I had with you. The other one, I think Ashley was there, and it was before you guys had privileges at Stony Brook. And so Ashley technically couldn't catch the baby. So we had a Stony Brook midwife who was so lovely, and they had such a great rapport. But I remember she was in her pushing phase, and in between. So, our culture's version of pushing is agony. Like, this is the most awful thing that could ever happen to you, and it's agony, and it's a bowling ball through an orange hole, and it's like, you know,
Yeah.
it's like literally it's torture. That's what we tell, or women are told. And this woman had her partner next to her. Her partner was so sweet because he hugged me. He had one arm on her and he hugged me in while the baby was being born. And Ashley was on the bed sitting with her at the perineum, and the other midwife was catching, and she was just so surrounded by like her initial circle of love that had been in the home. And I remember her laying back in between pushes and saying, "This is so wonderful. I feel so good." And I remember
That's how
meeting
it should
eyes.
be.
Yeah, I remember meeting eyes with Ashley and just being like, "This is," you know, it's like, so we transferred to the hospital. So what? Like, it didn't matter because her
Mhm.
team was with her. She still had the same feeling that she had at
Mhm.
home of being fully supported. It was such a beautiful, beautiful thing.
Yeah. And we're definitely not ashamed of like what we do. Like, we walk into any institution with our head held high. I will shake any OB's hand saying, "Thank you so much for your assistance," because this is what it's meant for. You know, the hospital is
Absolutely.
meant for women that need and or want that additional care, whether it's just an epidural, whether it's, you know, a belly birth, you know, everything in between.
Right.
It's a beautiful thing to be able to walk in and know that, you know, what we're doing is a service to women, and that we're appropriately utilizing the resources around us when necessary.
Definitely. I just want to add like one little tidbit about home birth, because you
Yeah.
know, I think home birth is like viewed as this new trendy dangerous thing, which obviously we're talking about how safe it really is and how wonderful it can be.
Mhm.
I when I chose my home birth, I'm very protective of my birth, and I'm very protective of my when I'm pregnant afterwards, you know, I was like, I
Yeah.
show everybody that would look at it my birth video. Here's my vagina. But beforehand, I'm very protective because I'm so vulnerable and because I'm so just private about it. And I remember not telling anybody I was planning a home birth. I didn't tell my brother and my sister-in-law. I only told my mother because I wanted her to be there. And then my father moved in with me. So I had to be like, "Hey, by the way, I'm definitely going to be naked in the living room giving birth. So maybe go out for lunch." And I remember telling my husband's family way after the fact. And I guess I expected some sort of like judgment and eye rolling and like, oh, you know, like, "Oh, you're like choosing all natural." And it was not the reaction I got at all. First of all, I found out my mother-in-law was born in an unassisted birth in the mountains of Honduras. So her mother was home alone and went into labor, and there wasn't time. So she caught her own baby. And
Awesome.
then, which I found like very beautiful, in that my daughter had that connection with my husband's family, like that he was the only one that skipped that like home birth
Uh-huh.
tradition. And then I announced to like a room, all of his aunts and uncles, there's like 7 of them. They were all in my living room. And I don't know, maybe I had a glass of wine and I started talking about my birth story. And I told all of them I had her right in the room we were in. And all of them just said, "Well, yeah, we were all born at home." And I was like,
Yeah.
oh, it just kind of hit me like, oh, home birth is the original. This is what all of our ancestors did. There
Mhm.
was no hospital birth. Hospital birth is actually the new thing. Hospital birth is the experimental thing. It's only been around for like 100, 150 years. And for eons, we've been birthing at home and birthing with skilled providers and
Mhm.
women supporting us. So it really feels, for me now, having birth at home, it feels like I'm really connected to our families in a completely different way than before.
That's
So
awesome.
thank you for doing all of that
Yeah.
wonderful home birth. So
So
before we
blessed.
sign off, I would love
Yeah.
if you could, for our listeners who are pregnant people
Mhm.
and planning a birth, and it doesn't have to be midwifery related, but what would your tip be if you had a tip about birth or parenting and you could tell them one piece of advice as they go into this time in their life? What would it be?
Um, just that the choice is always yours, you know, and you can say yes or no to anything. So I would highly, you know, recommend educating yourself, reading as much as you can, and asking a lot of questions. Because, you know, just when you walk into an institution, you're signing your consent forms. All you're doing is saying that I agree to these things if someone eventually talks to me about them, and I don't have to sign a separate form for everything. But you don't sign your rights away. and everything still comes down to you and your partner and what you guys are comfortable with. So ask questions, and the word no can be very powerful in a birth setting. So utilize it, and ask those questions. And yeah, that's kind of what I've always said about birth. You're not signing your rights away, and no is a good word to use. So
I love it. Be an active participant. That's beautiful.
Yeah.
And yeah, so thank you so much for sitting down with me today. This was wonderful. I learned so much, and I would imagine so did our listeners. Gaia Midwives will be on Be Her Village, so you can add them to your registry and all their great services. And yeah, thank you so much for.
Thank you. I appreciate it, Caitlin. This is so much fun.
Thanks, Colleen. It really was.